Good morning, good afternoon, good evening, ladies and gentlemen. My name is Bleeker. I'm the chair of the Global Action Against Mass Atrocity Crimes, and I'm delighted to welcome Dr. Professor Jennifer Leaning, who is in the US. So we are communicating from Switzerland to the US. Thank you, Jennifer, to be here. You are a member of our steering group. But in particular, I wanted to realize this interview because you are a medical doctor with training in public health, and you have spent much time of your life conducting investigations in conflict, post-conflicts, and disturbed situations around the world. Sometimes you have been working with Physicians for Human Rights, but more recently, you have made very important research in humanitarian crisis in your role as director and now senior research fellow of the François-Xavier Bagnoud Center for Health and Human Rights at Howard University. You're also a professor of practice of health and human rights at the Harvard Shan School of Public Health and associate professor of medicine at Howard Medical School. Actually, it's very interesting that you have this background because as you told me, issues of genocide and atrocity crimes, war crimes, surfaced in almost all the conflict areas effort that you conducted. And so you had to somehow become versed in these circumstances, history and legal/normative frameworks applicable to this situation. So you come here with a wealth of knowledge that we have the privilege to be able to share with you. And on our side, GAAMAC has been regularly suggesting that there are parallels, at least that we can learn a lot from the prevention realized through public health. And now that we are going through this pandemic, COVID-19, we would like to take the opportunity to systematize with you a kind of comparative reflection about public health prevention and atrocity prevention. We have therefore decided to conduct a series of interviews with you. So thank you so much that you have accepted and you have been, you are available for that. So it means also for our viewers that would you like to send us questions? In 15 days, we are going to conduct a next interview with Jennifer, and you can send us question in a written form, and Jennifer will be very pleased to answer them. So the first question I would like to ask you for us who are not specialized in medical approach or epidemiology is, could you offer us in a nutshell an understandable definition of public health prevention and epidemiology? And then I would very much like to ask you, in public health in particular, what are the main constituent elements of prevention, and consequently, what are the basic components that prevention of atrocity should entail? Would we already begin to make this kind of comparative linkages between the two fields? So thank you, Jennifer, you have the floor.
Well, thank you, Mo. And could I begin by acknowledging with gratitude your invitation to do this work with you and with GAAMAC. And I feel a great deal of humility in speaking to people from all over the world who are very conversant in these issues and more conversant in the issues relating to their individual countries than I am. So I will attempt to do what you just said, summarize in a nutshell. So public health is, it looks at the interaction between human beings and their environment in order to understand what harms are being created by these interactions, and to intervene to prevent the harm from starting or the harm from getting worse. And so the fundamental action of public health is prevention. And it has three categories of prevention. Primary prevention, when we get early warning that something is occurring, and the state and the local boards of health or the local officials intervene to stop that harm from occurring without affecting in any pronounced negative way any individual, let alone a population. The second form is secondary prevention, when we understand from our methods of ascertainment, from the way we look at the world, and I'll talk about that in a minute. The second method is secondary prevention, when the problem has arisen, harm is taking place, the public health authorities learn about it somewhat too late to stop it in a primary mode. And secondary prevention is often what we wind up doing in public health work throughout the world. The evidence comes in a bit late, or it takes time to evaluate that evidence to be sure that it actually is, not some fly-by-night kind of indicator that actually doesn't hold up when you really look at it. So there's an analytic step before you really get going, and that means that much of what we're doing is secondary prevention. And then we are also doing, always in public health, a parallel action called mitigation, which begins with primary prevention. You see something that is really potentially dangerous, so you intervene to stop that. But then there's a mitigation effort to be sure it isn't happening elsewhere in the country, or that there's something you found that the rest of the world needs to know about it, which is why WHO is very helpful. And that's in one way, which is very helpful. And then mitigation continues for sure with secondary prevention, I mean, because when something has already started and you were working to stop it, part of the process is to try to reduce the harm and heal people and make them have access to more information and ways to protect themselves as you are trying to prevent, in a secondary mode, the harmful effect to percolate through the population.
So, Jennifer, when you describe this, this is in public health, and now would we transfer this to prevention of atrocity? I immediately understand, and my first question to you is that it means that early warning, you might somehow agree on what are these early warnings. So how would you transpose this? What would it mean, as far as we can go, of course, in these different fields, but comparing public health prevention to prevention of atrocities?
Well, the two fundamental relevant approaches to public health here for prevention of atrocity, I would say, are one, the method of epidemiology that we use for scanning to see what's going on. Okay, I come back to that. And the second is that the intervention method of public health begins with an early alert and then early warning. So we scan in epidemiology, which is a statistical method, the distribution and rate of harmful conditions in a population. So that begins by always being aware of baseline public health data: births, deaths, migration, racial and ethnic composition of the population. But then when you look at what is going on that may be a problem, you are looking at, say, an increase in neonatal deaths using the monitoring data. You look at issues that relate to deaths of a particular population segment that should not be dying, like the deaths of young men, which were a very big alert for the HIV/AIDS epidemic. When in San Francisco, this began reported, and there was just no understanding of how this could be the case. And so you scan for departures from the normal. And then when you find something that is a departure, then you look more deeply into it. And in public health systems, we have developed what we call surveillance. That is, you look at certain things that you understand are likely to be problematic, like visits to the emergency department or reports of domestic abuse. And so we're always looking at these issues And when they are beginning to increase in frequency, which is always what you're doing, frequency against a background stability, then you signal an alert. It's called an early alert. Hey, there's an increase in domestic violence in this city in the United States. What is going on? And then you talk to the local authorities, you construct some further studies, and you basically then will get into a more robust understanding of what's going on, and then you issue an early warning.
Okay, Jennifer, in other words, that would mean, because in public health you have that, you have a permanent architecture that is always working, right? Mm-hmm. And so you have the capacity very early on to recognize and agree about the nature of a problem or virus or etc., which is quite different, I would say, in a prevention of atrocities. So can you tell us this? It has to do, we have seen that also with the pandemic. And I think in our initial conversation, it was very interesting to listen to you, because you were saying how governments have reacted in a very different way, understanding what was happening in the early stages in a very different way. I think that could help us also to understand better what are, if we want to really be able to prevent in atrocities, we need agreement on early warning elements, right? So we need people to talk with, and we need mechanism of cooperation. So how would you follow up on that?
I think there are a lot of parallels between prevention of atrocity and the concept of prevention in public health. The field of atrocity prevention is based on our understanding of the ways in which societies have been split into very ugly and dangerous ways around certain fault lines of the other. And there's a robust history of mass atrocity and atrocity crimes, to the extent that much more than in public health, there is very strong international law regarding the ascertainment and intervention and the legal sanctions for grave commission of atrocity crimes. What is different is, just as you say, in every country in the world, we either have very strong and robust systems of monitoring and surveillance in public health issues at the nation state, and then at the provincial or state level. And that is not in place for mass atrocity or atrocity prevention. Yet we know many of the indicators, and that is one of the issues we talk about in GAAMAC. That is, what are the features that we must be looking for as we're setting up now the national focal points and interactions with civil society? What are we going to be looking at? How do we define that concept of hate speech? And then how do we signal an alert that actually the level of hate speech, which is always on, in some way, endemic in a society, there's always grumbling and nastiness. But what then triggers an alert that this is actually getting into a dangerous zone in terms of volume or change of vocabulary, and or instructions to take action based on the hate speech? How do we quantify that in a way that the province or the nation state can trigger an early alert and then issue an early warning and then activate processes for intervention? So the mechanisms of acknowledging and enforcing prevention in mass atrocity are not so routine or so well understood as they are in public health. And that
so you would actually encourage that to happen, if I'm understanding what you are saying.
That's why
right?
I think the GAAMAC and the whole movement in the international community to be able to identify and intervene early in an alert and then a warning and then substantive action, that effort is crucial in prevention of atrocity.
Okay. If we go back to COVID-19, right? We have seen different government understanding or reacting to this pandemic in a very different way, with different strategies. Some saying we are going to develop a kind of national immunity. and natural because people will be infected. Others have been saying, well, this doesn't exist, huh? Denial. And others have been saying, no, we need a very immediate reaction, and we can make distinctions between context, I would say political and cultural context. So it tells us about reactions. It tells us about who informed this government, the relation between power, politics, and scientific community, and then the context themselves. What can you tell us about that?
Well, that's a rich question. I would say first that the coronavirus was strange to everybody in the medical and public health community. And I think also to the general public and in the political world. We'd never seen this virus before. So we didn't know how it worked in any way. And I can come back to that if we have time. So it stunned everyone. On the other hand, just as with atrocity and just as with other endemic diseases, once we realized it was a virus, there are certain instincts that kicked in about what we had to do. We had the recent experience of the SARS epidemic, where in Hong Kong, there was a rapid move to test people, trace contacts, and try to lock down the disease. It spread to some extent, but it was pretty well dealt with once there was a recognition. In this case, there was a initial failure to understand in the public health world, and there's no one to blame for this, to understand how absolutely contagious it was. It is much more contagious than some of these other viruses we've had. And it took a while to realize it's about 10 times more lethal than seasonal influenza. And this experience we noticed coming out of Wuhan. Now there's all these issues about should we have heard earlier from the Chinese or not. But as the months have gone on, we have to realize how much we have learned from the Chinese and how much we actually have yet to learn, in my opinion, in terms of stability of social distancing and social control around public movement. But the strategies for how to produce a positive reaction to this virus had to be developed and instituted in a very short time frame. And so a big problem around the world, but I would say particularly in the United States, was a failure to take the early alert and the early warning coming out of China and introduce early preventive action. So we began in the United States in a full force public health effort of late secondary prevention.
Okay.
And that is a very big problem because of how virulent this virus is. Now, other societies took earlier action, and there the diversity of actions are very interesting, which we could explore. But every government had to look at its society and decide what that society would tolerate in terms of the evidence the state had for the action it asked for. Lockdown, social distancing, mingle in the parks, but you should not go to the restaurant. I mean, the more subtle and conflicting these messages are, I would say to some extent, they've created confusion in the general public, which is not a good idea when you're dealing with a disease that is this strong.
Okay, so what you are saying, Jennifer, trying to knit or to build bridges between these two worlds and universe, is you are saying first there is a scientific community that recognized or identified a serious problem, right? Mm-hmm. And they communicated it to policymakers, to politicians and to governments, right? And so you're already pointing the finger to the fact that some governments might listen indeed, and some other might not listen, in spite of the gravity of the situation. So that's very analogical to the situation in atrocity prevention, right? Mm-hmm. When we denounce hate speech or we denounce serious violations of human rights, we often have difficulties to be taken out to generate a political will to act, right? And then generate political strategies that are going to mitigate or to impede this to become really to enter in a kind of atrocity-prone spiral, right? So scientific community, so objective facts, and we have here decades of historians and all kinds of professionals who have developed an understanding of this phenomenon of the construction of the other as an enemy, which is really the basic of the creation of atrocity. And then you have their relation with political powers who are inclined or not to listen to them. And then you have political action. Am I understanding you properly?
Yes. And in public health, the diversity of populations is something one has to take account of when you're doing the messaging, which relates to the issue of prevention of atrocity. More diverse populations in general for public health require more delicate messaging, more nuanced messaging, so that particular groups do not feel stigmatized when you're trying to protect the whole population from a disease that is actually contained with individual human bodies. So the people who have the virus, do they need isolation? Do they need identification? Do they need to be taken out of a certain place but allowed to stay at home? All of these are very draconian measures that under public health emergency law, at least in the United States, and I think in many other countries, can basically almost require politicians to take these actions. If you in a state declare a public health emergency, then the governor of that state has tremendous authority to do whatever he thinks is necessary with scientific advice. So in the state, the sense of atrocity, early warning, and then the declaration that this is actually reached a level of high concern in terms of the numbers of people implicated, the numbers of people that are killed, the numbers of people who are ostracized, the numbers of people who are afraid and fleeing. I mean, so numbers come in, even though an atrocity is a legal and socio historical concept. Even when you're acting on atrocity prevention, there is a certain way in which a government is going to look at numbers. As much as the pure legal people or the analysts of atrocity might say, one issue of hate speech in a radio broadcast doesn't make an atrocity that you have to deal with. And that really makes sense in the sense of this judgment about numbers or intensity in atrocity, which is the same thing we have in public health, is that there's a range of normal, or there's a range of tolerated day-to-day behaviors, or a range of normal illnesses that we get used to. We always want to decrease the number in that range, in atrocity and in public health. But there are thresholds that actually we understand, both in public health and in atrocity crimes, thresholds that you really don't want to cross. And those are based on both numbers, I'm now speaking about atrocity in public health, and intensity in an action in atrocity assessment. But in public health, you then speak about the deadliness or the contagion of the thing you're warning about. Coronavirus is relatively deadly and highly contagious.
So what we have observed as we are getting to the end of our first interview, I mean, we are opening really a very interesting conversation and very nourishing, I believe, for the community engaged in prevention of atrocity. First, as a kind of synthesis of what you have been talking about, is the importance of the facts, the numbers, the data, and the independence of scientific communities that is assessing their nature, the kind of risks that they are posing. As you were saying, COVID is highly contagious, but maybe not so deadly, while other viruses can be and deadly and highly contagious, all of them. So Second, it's a kind of dialogue that is existing between this community and the ones that have to take political decisions.
Mm-hmm.
I guess then after it's the array of possible decisions to be taken that might have been basically foreseen before through protocols of cooperation and possible decision that can be taken if this or that is happening. So it tells us that, in analogy with public health prevention, basically you need an architecture which is already there if you want to act timely. Otherwise, you only can come when the pandemic is already there. The pandemic of hate speech, already incitement against specific group. So would you like, and as a kind of conclusion of this preliminary first conversation, tell us a little bit more about that and give us a little bit 2 or 3 insights that your recommendation as epidemiologist and medical doctor for the prevention of atrocity community?
Well, I would say there's sort of 3 points. One, I think we may have established, I hope persuasively, that there are important and constructive parallels between the work of prevention in public health and the work of prevention in the commission of atrocity crimes. And the disease model has some strong similarities in terms of what one is seeking to prevent, the spread of it. I mean, I'm not saying it's a tight parallel, but it's an interesting one. I think there is a need for, in atrocity prevention, in addition to the need for an architecture, a system of monitoring, and then a system of producing early alerts and then early action. There's a need for a common language across cultures and societies in atrocity prevention, that every nation state, and to the extent that you can get the concurrence of society, that every society and nation state recognizes that these are the key issues that have to be tracked, that have to be looked at, monitored, and that these are the indicators of those conditions that suggest
in your own context, yes,
worse in your own context. So there are key conditions that are probably core to all societies, definitions, and then there are some that may be actually peculiar to a particular society based on its history, and then there are going to be indicators. But the more we could have a dialogue across societies and culture, the more likely it is that we're going to have states conform to the international law, and more subtly, states intervene to make conditions of life better for all of those who are at risk.
Thank you, Jennifer. It was a wonderful first interview to try to begin to unpack the relations that we can create somehow by reflecting between public health prevention and prevention of atrocities. It's really amazing, and I wish to continue this conversation. We'll meet again in 2 weeks to continue this conversation, and hopefully we'll receive a lot of questions by viewers and pursue this very interesting conversation. Thank you very much, Jennifer, and stay safe and stay at home. Thank you.
Thank you very much.